Great. Welcome. Good morning, good afternoon, and good evening. Thank you all for joining us today. Today's webinar is titled Tracking and Visualizing Family Planning and COVID-19 Adaptations and is brought to you by the IBP COVID-19 Task Team, which is hosted by the IBP Network, FHI 360, and the Johns Hopkins Center for Communications Programs. Thank you again for joining us today. My name is Nandita Thate from the IBP Network at WHO, and I'll be moderating today's session. If you could go to the next slide. We have a very exciting agenda today. I'll start by giving a brief overview of the IBP COVID-19 task team, and then we'll hear from two of our partners who've done some interesting work on documenting and visualizing adaptations in family planning during the COVID-19 pandemic. We'll start with our colleagues from PSI, and then we'll hear from FHI 360, who has been instrumental in creating our map. And then finally, we will end with some time for questions and answers and some discussion. Next. Before we begin, just a quick housekeeping note. Please do submit your questions at any time. There should be a little box below your screen. And also note that today's webinar will be recorded, so you can watch it later or share with your colleagues. We will post it on the WHO HRP Media YouTube channel. It will also be posted on the Knowledge Success site. Next. Just a couple of notes on the IBP task team. The task team was started in April of 2020 at the start of the COVID-19 pandemic. And the purpose was really to share new guidance coming out of WHO about how to manage COVID-19 and how to maintain critical FP and SRH services during the pandemic. But it also became an interesting platform for partners to share their experiences in adapting family planning programs in their country and in their work. At the time, as you can imagine, there were a lot of different groups convening, so it also was a great opportunity to share lessons between these different groups that were all trying to manage the COVID-19 pandemic and making sure that essential SRH services were still being maintained. Next. Our activities are mainly focused around a lot of knowledge exchange and sharing. We host regular task team meetings. At the beginning of the pandemic, we were meeting every 2 weeks. We've now reduced that to meet monthly. We also continue to host our webinar series. In the beginning, we had several regional webinars in multiple languages, and we are now doing some follow-up with many of those partners. We recently hosted a webinar in December with our partners in Asia who have managed to control the pandemic fairly well, and we'll be hosting some other webinars in the coming months from our partners in Africa and Latin America, as well as Europe. We've also made some efforts in documenting adaptations in family planning programming, and that's what we'll be talking about more today. Next. Just a quick note on how this process started. It really started with a spreadsheet, a Google document. Partners were asking each other questions. Well, what have you been doing to modify your FP programming? How are we making sure women and girls and families are getting the services they need during the pandemic? So we asked partners to start entering information into this spreadsheet, a Google document. And we asked for challenges, adaptations they made, contact information, and we started organizing it around service delivery, enabling environment, and social behavior change interventions. Once we had a good amount of information in there, there was a request from many of our partners on how we can better visualize this information. Could we put it in some sort of map? And that's what we'll be talking about today, is how do we take all this information and package it in a way that's easy to use and share with others. So I will leave it at that. If you go to the next slide, you can find additional information on how to join the task team. We have a site on the IBP Community Engagement Platform that you can join. We also have a listserv that you can join. The information is at the bottom of the slide there. So with that, I will turn it over to our next presenters, I'd like to welcome our colleagues from PSI, Lola Floman, Dr. Millie Kagwa, and Dr. Eva Lathrop. I'll turn it over to you all. Thank you.
Good morning. My name is Dr. Millie Kagwa. Good afternoon for those of you who are in the East African or African continent. Good afternoon. For those of you who have just joined, my name is Dr. Millie Kagwa, and I work as a Senior Clinical Advisor at Population Services International. And I'll be taking you some of the SRH adaptations that PSI country platforms have implemented during the COVID-19. I have a team with me. We have Lola, who will finally introduce herself. She is she's a consultant on the PSI, a PSI consultant, and we also have Dr. Eva Lathrop, who is our Global Medical Director. Laura, please take it down for the next slide.
Hello, everyone. Thank you so much, Dr. Millie Kagwa, for that introduction. Like Millie mentioned, my name is Lola Floman, and I'm a technical working consultant for PSI, and I work mostly in the research department. And so before we begin our presentation today, I just wanted to take a moment to express how incredibly rare it has been in this challenging COVID-19 context to really take a moment and pause and reflect on all the incredible resilience of all the FP program country teams across all of our organizations and programs. And so we really are looking forward to taking this moment together to collectively reflect on all these adaptations across the country platforms, and also just share a little bit more about PSI's approach to share these lessons learned with the larger global health community. And so without further ado, we can see our agenda here, and we have 4 parts to our presentation today. Of course, we'll begin with a background to discuss a little bit further as to why this map was created in the first place. Following the background, we'll be able to take a look at the key data behind the map and present some key results. The second half of the presentation will focus a lot more on the impact of the map. And so we'll be able to hear some testimony feedback and discuss some of the statistics of the reach of the map. But most importantly, really talking about how the program adaptation monitoring has been able to impact and accelerate learning across different country platforms. And then last but not least, we have this final point here about what's next. And so, of course, we acknowledge and wholeheartedly appreciate that COVID-19 is still impacting all FP programming around the world. However, PSI country teams have also begun to recognize that certain adaptations are really successful, particularly in their cost effectiveness at increasing our client reach. And so we'll be able to share a little bit more about what are those adaptations and how PSI plans to incorporate those adaptations beyond this COVID-19 context. Thank you so much. Next slide. And so let's take a little bit of a look about the background and talk about why the map was created in the first place. So when COVID-19 first appeared at the onset of the pandemic, PSI country platforms really began innovating, particularly their health service implementation approaches, to really make sure that they were able to continue providing services, but while keeping our clients, communities, and staff members safe from COVID-19. The problem began that all of this amazing creative adaptations and innovations were happening, but PSI really lacked a way to monitor all of these different adaptations that were happening. And so critically, PSI lacked a centralized and accessible way to track and learn from these program adaptations, and particularly a way to learn from them in real time. And so the solution became to really design an interactive map that had 2 primary goals. Firstly, of course, to document and monitor all of the amazing adaptations that were happening across the different country platforms. But secondly, and arguably more importantly, to share these adaptations to accelerate learning, and particularly the adoption of these successful adaptations across the platforms. And so just before we continue, to make sure that we're all on the same page, When we discuss an adaptation, what we are really talking about is any modification made to a planned program's activities, interventions, approach, or funding, specifically as a direct result of COVID-19. Thank you. Next slide. Great. And so now that we had some sort of a solution to be able to centralize these adaptations, we had to come up with a plan to obviously execute the map. And so the goal for this map was really not to create something that was static. We didn't really want a snapshot, but we did want something that captured this living resource on how PSI was able to pivot as the pandemic evolved. We really wanted something that adapted and updated as PSI adapted. And so the execution strategy, therefore, became twofold, stressing the fact that we wanted to be able to share the adaptations. The thought was to create two different maps, an internal map and external map that captured these adaptations across all four health areas, and stressing that we wanted this map to be a living resource. These maps were updated every 2 weeks on a bi-weekly basis. And so you may be asking yourself, what's the main difference between the internal map and the external map? And so for the internal map, the main goal here was really to capture these qualitative adaptation descriptions and to be able to categorize them across PSI priority strategy categories. And the main point here was to promote cross-learning across PSI different platforms. Whereas the external map was a little bit more high level and more of an overview format of generalized adaptation themes. And of course, the goal here was really to promote more organizational cross-learning. And so I think it would be fair to say that this was very much an all hands on deck effort within PSI. And so we can see here that the map design was really driven by a number of key people within PSI, particularly PSI's internal COVID-19 response working group, which is led by my co-presenters who are here with us today. In addition to that, we had health area technical leads, we had representatives and leaderships from strategy, from research, and even from external communications to make sure that everyone was able to participate and that we had a really collaborative cross-cutting approach to designing the map. With regards to data collection and validation, it was also very much an all hands approach. The data collection was primarily done by program managers who are essentially support teams that are majorly based in at PSI headquarters. And they were responsible for populating the map data every 2 weeks, primarily from their insights from speaking with field offices. And then validation was also done through a number of ways and was also quite collaborative, including point people from the research team, regional managers, as well as a point person for language and harmonization. All this to say that this was very much a collaborative effort that hadn't necessarily been mimicked within PSI before. And so everyone was able to come together quite rapidly to execute this important map effort. Data collection occurred from May to September of 2020, so approximately in real time as the pandemic was evolving. And the map was populated similarly to how Nandita demonstrated on a simple Excel sheet that was updated every 2 weeks. Next slide, please. And so we will be sharing many learnings from the map today, and we thought it would be wise to take a moment to really look at the data of the map and see exactly what we're talking about, since some of you may be familiar with the map and some of you may not be. And so the interactive map really tracked adaptations across all PSI platforms, as well as health areas. We also really wanted to be able to capture adaptations that focus specifically on COVID-19 prevention. Now, if we take a look at the screenshot of the map in the lower corner here, I'll be able to walk you through an example of Niger. For instance, with each country, you were able to click on the map and see very detailed aspects of each adaptation. In this example here of Niger, you were able to see everything from type of response, which is included across health areas. We ascribed a response subcategory to try and make it as specific as possible. You were able to see what project was implementing that particular adaptation, a description of that adaptation. We also really wanted to be able to track who was funding that adaptation. And so in this case, Global Affairs Canada. And then last, but certainly not least, to promote cross-learning, of course, we had a contact point information for each adaptation with their email address that people could reach out to learn more about the adaptation. So when we traditionally think of data visualizations, they can be quite complex. All of the amazing Power BI interactive dashboards come to mind, as well as our shiny coding packages, and all of that is fantastic. However, with this data visualization, we really wanted something that was really accessible, really user-friendly, and really accessible in a way for people that were data literate and not necessarily as familiar with complex indicators and R scores and such. And so in this way, you can see that we have a legend next to the map. And this was a simple way to be able to filter out data and have that customized experience for someone who is visiting the map. And so you could simply click on any of the titles within the legend and the map would filter automatically. So as I previously mentioned, of course, you can filter by COVID-19 prevention adaptations, but you also can filter by each health category within PSI. And then outside of those health categories, the PSI leadership really thought that it was important to track these strategic response categories in each country adaptation. And so we can see here that you can also filter the data by digital health, social behavior change, quality assurance, and all of those other categories listed. And so while I mentioned that the adaptations across all PSI platforms and also focus on all health areas, today in our learning discussion, we will focus exclusively on family planning program adaptations. Thank you. Next slide. Thank you so much. And at this moment, it is my pleasure to hand over the presentation to Dr. Millie Kagwa, Senior Clinical Advisor and the Clinical Lead of the COVID-19 Rapid Response.
Thank you, Lola. I'll just be taking you through the SRH adaptations that we had. And in the next couple of slides, I'll talk about what PSI platforms have implemented during the COVID-19 pandemic. I'll take you through a global overview, take you through some FP adaptations, and finally, some lessons that we've learned from these adaptations. Next slide, please. So in this slide, this is the global overview, just to bring down what Lola has been talking about. The PSI adaptations spanned 3 continents. We had adaptations in Latin America, we had adaptations in Asia, some countries in Asia, and the bulk of these adaptations were in Africa. And since May 2020, we've had over 318 program adaptations across 4 health areas. These health areas are reproductive health, malaria, HIV, and WASH. And they come from 45 countries. Slightly over 50% of these, half of these, were in FP programs. And these came to a total of around 125 adaptations from 36 countries that directly mitigated the spread of COVID-19. And in this particular slide, we're talking about those that have been documented. As you can see, the PSI countries moved pretty quickly to adapt to this changing environment. And I'll say it has been a success to document these learnings and to monitor these learnings. We've seen 2 common COVID-19 themes, prevention themes that have emerged. One is the social behavior change messaging, and also the direct provision of personal protective equipment to providers. Next slide, please. So in this slide, I'm just going to talk about the actual FP adaptations. There've been 168 adaptations across 35 countries. And the majority of these, across 36 countries as mentioned, and the majority of these occurred in Eastern and Southern Africa. the majority fell within three main areas. The first one being social behavior change and demand generation. We saw a lot of use of radio messaging. We saw chatbots for family planning coming up and being utilized. We've seen 46% of all the FP adaptations concerned with with social behavior change demand creation. And then we also saw an increase in the use of digital interventions. 2/3 of that adaptations utilized some kind of digital platform like WhatsApp, maybe a hotline or Facebook. And then we also saw youth coming to play, working with youth designers and mobilizers for FP for demand generation. Next slide, please. So we wanted to break down these FP adaptations to see how have they have they fit into the high impact practices, sustaining high impact practices for family planning. And what you see there on the right hand side is in that pie chart is a breakdown of how these interventions were broken down by high impact practices. The majority fell under the service delivery. Followed by social behavior change, and lastly, we had a few in creating an enabling environment. We saw common adaptations that addressed service delivery, including provision of personal protective equipment, not only to providers, but to community health workers. We saw remote social franchising, capacity building, and we also saw the use of digital interventions to maintain service delivery. So for instance, we've had 65% of the adaptations using a digital platform like WhatsApp, Facebook, or e-referrals. And in this, we also saw social behavior change as the most common adaptation included social media use, radio, social distancing, community engagement for promotion. Lastly, we had adaptations that were aimed at creating an enabling environment for FP. We know FP is one of those services that could easily be ignored during a pandemic or during such big changes in environment. So some countries worked with their ministries of health. They partnered with the ministries of health to see that they have a social behavior change strategy that is developed, and others worked again with partners and Ministry of Health stakeholders to see that there is SRH emergency strategies for their countries. Next slide, please. In the next slide, I'll just talk briefly about what we learned. There's a lot of lessons. As I say, the adaptations were really, really many, and some were really individual. We've tried to bring those into groups so that it's easier to understand and draw lessons from them. But what did we learn? Clearly, the pandemic called for SRH programs to be flexible, to be nimble, and also to be able to adapt to the changing environment. We've seen a rapid uptake of digital tools for demand generation, for service delivery, and for quality. So digital is cutting across. And then we also saw that because of the lockdowns and limitations to movements, we've seen a focus on the last mile delivery of services, such as door-to-door, the use of unconventional transportation like motorcycles and bicycles to actually deliver family planning methods to women in their homes. We've seen the use of community health workers and volunteers to actually move services and to provide family planning together bundled with maybe some other MOH products that they were delivering. And then we've also seen that programs have continued to provide ongoing support to providers despite the difficulty, to providers, to pharmacists, and to their community health workers through trainings, e-trainings. We've seen support groups also coming up. Lastly, we've seen the sustained and consistent SBC messaging for both rural and urban communities. There's been a lot of myths. I think COVID has been, the COVID pandemic is one that has led to the most myths that I have ever had. There's been so much that is not true, spread again, mainly by social media and these digital platforms. So we've seen platforms trying to respond to that using the very same platforms, WhatsApp, hotlines, to try and address those myths and misconceptions. And next slide, please. Thank you. I'll hand over to Dr. Eva Lathrop, the Global Medical Director at PSI. Thank you.
Thanks, Millie. That's great. Okay. Let me make sure we're on the right slide. Yeah. Okay, great. Thank you, Millie and Lola, so far for your remarks. These are great. And good morning, good afternoon, good evening, everybody. I'm Eva Lathrop. I'm the Global Medical Director at PSI, and it's great to be with you today and to see so many folks online joining this. And as you can hear from our remarks so far, the creation, analysis, and learnings from our story map have been immense, and we've had a lot of fun creating and using this innovative tool and continuing to think about ways that we can keep sharing this approach to documenting and learning. Next slide. So of course, we were really interested to hear how this map had been used internally with PSI. So what did we hear from within PSI about the value of this map versus just using an Excel spreadsheet, for example, to track and document? We have selected several quotes here from among many of reflections on utility and impact of the map as a documentation and tracking tool from colleagues throughout PSI. One program manager stated that as PSI has mobilized quickly to meet this new global challenge, the map makes it easier to see what we're doing, where, and how to find out more information, describing the map tool as an on-demand, user-friendly source. Several colleagues found the tool useful as a centralized knowledge hub. One of our regional social media managers stated that the map helps support the different country teams' efforts in centralizing details regarding our COVID-19 response and help to strengthen the narrative of our response. And a program manager described the map in this way. It was especially useful for responding to donor information requests. We can review the information compiled there rather than having to provide information to them directly for each program and each project. And I'll say that this was a surprise to me, how often we referred back to the map for donor requests throughout the course of the last 10 months. So that turned out to be kind of a surprise utility of the map. And finally, another program manager leading implementation in one of PSI's country platforms remarked that the process map communicated accurate information and minimized the burden to the country teams who really needed time and space to focus on the COVID response. And in essence, I think this person was saying that the work of tracking adaptations was really on our HQ program support teams rather than on the program managers in country who really needed to do the actual implementation. Next slide. Okay. So of course, we've also been keen to learn about external reach of this map. And since its launch in June 2020, we have had over 2,600 interactions with the external map. The majority of those visitors have been from the US and the UK, and over 560 interactions with the internal map. So we had a slightly different version on our internal PSI website. So we're excited about this, but in reality, this is modest and largely centered in the US and the UK. So we need to continue to explore ways to expand reach for use by countries and organizations outside of PSI, but located in places where the learnings could be immediately applicable. What we don't have in this reach data is any qualitative feedback from these external users. So we're continuing to think internally about how we can capture more detail from external users to learn best ways to use and expand the map. This map exercise also inspired external partners to create similar maps. For example, the Prevention of Unsafe Abortion Partners Group, which is a group led by WHO and the UNFPA and is comprised of several other INGOs working in the safe abortion space. We worked together to develop a multi-organization story map documenting both quantitative and qualitative aspects of adaptations in the context of COVID to protect programs in safe abortion across the globe. And learnings from our first story map experience, in this one, we built in a mechanism to gather information and feedback from users. So with this one, an external user has the opportunity to take a really short survey at the end, but add feedback in the response and why they used it and what questions they might have and how we could do better. So I think that that'll be really helpful for us and is an example of how we iterated on our internal experience at PSI and have grown this, the use of this technology and learned from it and making it better. So we hope also to present this, this work with the partners group on a webinar similar to this one and continue to disseminate this approach along with the learnings and what more can be done to maximize use and impact. And of course, after this presentation, we'll hear from the IBP COVID-19 response team on the development of their map right after this presentation. Next slide. So what's next? How do we capture all these learnings and incorporate adaptations as we continue to move through this pandemic and beyond the context of COVID-19? Next slide. So the COVID-19 response map inspired new avenues at PSI for cross-departmental collaboration and rapid data sharing across country platforms. And I think in some ways, this has provided us with a blueprint for how to collaborate across our organization and within. PSI, I think, is now more ready than before to respond to subsequent local and international crises by capturing and sharing new learnings in real time. And I think we're also ready to communicate better and respond to each other even outside of the context of crises. As the pandemic evolves, PSI intends to continue to utilize these recently adopted digital tools for demand creation, service delivery, and quality assurance. Those are some of the really common themes that elevated from our adaptations. We also hope to continue to support providers, pharmacists, and community health workers through some of our new e-learning platforms. I don't think we'll go completely to e-learning, but I think there's a utility of e-learning well beyond the context of a pandemic. Even when we can be together again, I think we'll end up having some sort of a hybrid here. And then we hope to, of course, capitalize on COVID-19 government relationships and new partnerships that we've made to continue to advocate for a lot of this work across different health areas. And finally, as we emerge from the pandemic, we hope to take the learnings from these adaptations documented through this innovative technique. And there's still so much for us to learn about what we've done, what we've rapidly advanced, access to care. Some of that is through digital and self-care intervention and other adaptations. And we did these adaptations and we did them quickly out of necessity in the context of COVID-19, but we want to harness these learnings and make sure that we can make evidence-based recommendations on what of these gets incorporated into future programming. And I think that will be a big contribution. Next slide. There were so many people at PSI who are involved in the creation of this story map and the collection of documenting all these adaptations, but we want to give a particular shout out to our PSI program management teams. They were enthusiastic, they worked really hard, put in tremendous effort to document and share these adaptations. So when you have time, this is the link to our map. I hope you get a chance to interact with it today, but don't do it now because I'll pass the mic back to Nandita, who will introduce our next speakers to talk about their map. Thanks very much. I'm looking forward to your questions.
Great. Thank you, PSI colleagues, Lola, Millie, and Eva. That was a fantastic presentation, and I think really highlighted some important things for all of us to consider moving forward. One, how do we define adaptations? And I think you all did a fantastic job of doing that. Two, thinking about how these adaptations can continue beyond COVID-19. And I think there were some really interesting lessons learned about how we can continue these adaptations to further strengthen FP programming. And then it was great to see that your map has inspired others to do similar activities. And we will be hearing about that now on behalf of the IBP task team. So I will now introduce our last speaker, Trinity Zan from FHI 360, who will talk about the IBP Network map that we've tried to put together with our partners as part of this task team. So Trinity, I will turn it over to you. Thanks.
Thanks, Nandita, and thanks to all of our previous speakers. My name is Trinity Zan, and I'm the Associate Director of Research Utilization at FHI 360, and also the lead for research utilization on the Research for Scalable Solutions project. And so we are one of the co-hosts of this task team, and really thrilled to be here today. And just want to, again, congratulate PSI and thank them for all of this work, and in fact the inspiration for what we will be presenting or what I'll be presenting at the end of this presentation in just a few minutes. It's actually really interesting because you might say, you know, we were all kind of equally inspired knowing that we were about to be walking into the fire of hectic program adaptations in this pandemic to try and capture it. And so the IBP task team started with the Google Sheet sheet that Nandita mentioned, and we're trying to capture that information in real time, and then learned about PSI's map and thought that that was a very wonderful way to make that information accessible. And as Nandita also mentioned, people within the task team were asking for something that would be visual and more digestible. And so it was really great to be able to speak with them, learn from them, and use that to inform the map that we've recently created. So next slide, please. I'll just kind of go through this quickly. Nandita already mentioned the kind of goals and objectives behind the tasks team, really looking at the bottom of the slide, wanting to help us know what worked well and what didn't, to inform future scenarios. And although the information that we may be collecting might only be scratching the surface, I think what's important is that we have it documented, we know where certain things were happening, and contact information so that we can go back to that and try to dig deeper when we want. So next slide, please. As I mentioned, I'll actually be presenting a little bit about some of the trends from the information that was collected from members of IBP who submitted into that Google Sheet, and then how we've transitioned that into the map. And a lot of what we've seen in the entries very much echoes what PSI presented. So just as a snapshot, in the Google Doc that the IBP task team created, we had about 38 total entries thus far. And of those, we've now put up and posted 18 of those to the map. We have a process where we're asking people to please consent to letting us put that up on the map. So you may have gotten an email in your inbox if you put something into our Google Sheet. And if you haven't responded, don't fret. We will follow up with you again and hope to get your information into the map. So I'll circle back to the map at the end of the presentation. But next slide, please. Let's just quickly kind of go through some of the themes that we've seen in the entries that you all submitted to this Google Sheet. Again, challenges, as Nandita mentioned, we captured the type of program, the types of challenges people were facing, and then how those adaptations were implemented. And so nothing surprising here. We all know this. It's a lot of what we've been talking about over the past almost year. So I won't overburden you with this, but as we can note, there were kind of general types of challenges. There were ones that really affected the health system, and then there were, of course, ones that affect individuals. And so I should note that because we were asking people just to enter information into this Google Sheet, if people talk about hesitancy among individual clients to go visit services, or fears and myths and misconceptions, as well as decreases in utilization, those are all kind of qualitatively self-reported. So I just want to make sure that that's clear. Next slide, please. So we categorized, as Nandita mentioned, the types of adaptations into the service delivery, SBC, and then kind of enabling environment, which really focused on advocacy and policy. And so I think a lot of us really pushed in the initial moments for a focus on advocacy to ensure continuity of services. And so a lot of people reported those types of focused adaptations within their work in how to work with governments to develop additional information or policy guidelines utilizing resources from WHO and UNFPA and other organizations. Next slide, please. But then the bulk of the adaptations that people noted in the Google Sheet were actually focused on service delivery. I think PSI presented on a range, and in fact, if I heard correctly, noted that most of theirs were actually with SBC. So that's just an interesting difference. The majority of those posted into our Google Sheet were focused on service delivery, and those kind of fell into general categories. And here we're calling them general service delivery adaptations. But some of these also fit within the category that PSI presented on kind of COVID prevention. So you'll see on the list things like procuring PPE, hand washing kits, cleaning products, etc. But there was also a lot of just kind of general adaptations to minimize crowds, work with client flow, create isolation rooms, etc. Again, no big surprise. So next slide, please. what we were really interested in for this task team was understanding how the family planning programs were adapting. So there were a range of family planning service delivery adaptations that were noted. Interestingly, we've asked people to talk to tell us whether they were implementing or adapting within a HIP, and we saw that almost all of the HIPs were a part of the adaptations that were noted in this Google sheet, which is really, really interesting. I think the one exception was post-abortion care. And again, things that we've been talking about for a long time, ensuring commodities are there. In some instances, people were promoting self-care, including self-injection. In other instances where countries may have made decisions to really offer and encourage the availability and use of LARCs where that might be appropriate for women, of course, always in the context of free and informed choice. People were doing multi-month dispensing of contraceptives, including alongside other medications like ARTs, and so taking advantage of those touch points with clients. As PSI noted, using moto taxis or other types of delivery platforms to get contraceptives directly to people, and then utilizing what kind of community infrastructure may exist, in particular community volunteers among youth and peer workers to get condoms to young people. Next slide, please. We did see a lot around digital. I think that everybody knows that a lot of the pivots have been toward the use of digital technologies, whether that's to help in supervision or actual telemedicine and e-pharmacies, or to conduct virtual trainings. And so as PSI noted, many people are currently in discussion about how and whether these adaptations will continue over time. I think that's a really interesting discussion point, and I'm putting a little plug in for the next webinar that the task team is organizing, which is actually focused on digital adaptations and is done in collaboration with the WISH project. So that's February 17th, so stay tuned when we can hear more about that. Next slide, please. There's also, of course, within the category of social and behavior change, a lot focused on digital. Again, I won't repeat myself since PSI very comprehensively spoke to that, as well as the use of mass media. And so what's interesting there is that in some instances, people reported adaptations or shifts toward using radio and television in order to get messages out. And in other contexts, people shifted away from those to focus on community health workers when they were concerned about drawing crowds if you're doing kind of big video displays or loudspeaker events. So we kind of got both sides of the coin there. Next slide, please. And then again, a HIP community group engagement, there was a lot of focus on leveraging the community while taking safety precautions into mind, both to reach people with information and services for family planning, but also using that to provide correct and accurate information about COVID-19 and other entry points. And so you'll see on the screen messages about GBV. And I know that in one of the past webinars that the task team hosted, we heard from a partner organization in Myanmar that was talking about the great opportunity that it actually provided to get messages about some of these more sensitive topics like family planning and GBV when given the opportunity to help spread accurate information about COVID-19. Next slide, please. We did also categorize and ask people about research and how they had to adapt research. And as you might expect, we had to shift from doing in-person interviews to using phones or online surveys. And there is a good bit of research that's underway among many organizations, and are for us included, to try to understand the impact of COVID-19, both on health providers as well as on users and their access to and use of contraception. Next slide, please. So now we'd like to shift to showing the map that we've used. So all of that information was a synthesis of what has been collected to date in the Google Sheet. And we've now taken up the process of shifting that information and migrating it into a story map, again, inspired by PSI. So Natalie, if you could show the landing page first, that would be great. So we've created a page on the Knowledge Success website to house this map. and we would invite you all to come and visit it. We'll put the address into the chat in just a moment, but it includes some instructions on how to use it, as well as a little bit of information about some of the trends, and also a Google form for those who are interested in contributing information. But let's take a look at the map, and we'll just quickly show you how to use it. It's, again, the same type of technology as PSI, and once again, thanks to them. So because we had asked people to provide information about the type of program, you'll see on the left, there's a little bar that you can expand and contract, and it shows you those adaptations that were done within service delivery or these other categories. So for us, the majority were service delivery, and then there are these other categories, and they correspond to the colors on the map. And so right now, that's the main filtering option that we have, but we'd love to hear from people about what type of information they'd like and how they'd like to filter this, if it's by type of challenge, for example, or even organization. So if you click on a country, what will happen is a box will pop up, and it will contain information about certain types of programs. So it'll just give you, again, a little bit of information about the organization, the COVID challenge, and a brief description of what that adaptation was. And if people provide contact information, then that is available. And again, we feel like that may be one of the most useful aspects of this, is that people can go and be in touch with somebody to get more information. So we can go back to the map now. We would invite people to play around with it, to look around, and then to provide feedback to us. I'll make a couple of notes. We asked people to give us information on a couple of aspects for which we haven't received that much information. So one is what types of indicators people are using to monitor these adaptations and whether they're working well. And I saw a question come through in the chat related to indicators. So we're very interested in hearing from you all about how you're monitoring these adaptations. And so we would love more information about that. And we also ask people to let us know if they are continuing or planning to continue these types of adaptations. As Eva was saying, digital is one of those categories of adaptations where we expect, many people are expecting actually to see a continuation. And so we would love to also hear from people about which adaptations were appropriate and acute, and, you know, for which we'll revert back to prior approaches, and which will continue. And so that's another area where I think we can have a lot of interesting conversation, but we would like to have that information within the context of this map. And so let's go back to this slide, Natalie, and we'll just show you how you can be in touch with us. Again, you can visit the landing page on the Knowledge Success website, and there is a Google form for people who are interested in having information about your adaptations visualized here, and we would be thrilled to include that information. There's also the links to join the IBP task team, so that would be another way to be in touch with us. And there is a Gmail account that you can email if you have any questions about this, if you have thoughts or feedback on how we could improve this, and if you would like us to be in touch with you to help get your information about program adaptations visualized. So I think I'll end there, and I know that we would like to move into a discussion about how we all can use this information, how we can make it as useful as possible for each other. And I'm really looking forward to hearing your thoughts and suggestions. I know that this task team and many projects, including R4S, are interested in supporting efforts to better understand what has worked and what hasn't worked. So thank you very much.
Great, thank you, Trinity. That was excellent, and a really nice overview of the map and the process. Thank you again to all of our presenters from PSI as well. I will now turn it over to Sarah Harlan from the Johns Hopkins Center for Communications Program and the Knowledge Success Project, who will walk us through some of the questions and discussion. I think there were a number coming through the chat. So Sarah, over to you.
Great, thanks Nandita, and thanks to Trinity and all of the presenters, Eva, Millie, and Lola. We're, as you can tell, very excited about the PSI map and about the IBP adaptation of the map. And Trinity's comments are a nice segue into the discussion that we're hoping to have on what to do with this information. So I'll start out just sharing some thoughts that we had as the task team and the co-chairs about how we envision using the map, and then we're happy to take your comments and questions as well. And just a note that since we're using the webinar feature of Zoom, participants are not able to speak, but we encourage you to use the chat window and add your comments and questions about how we can use the map. And then we'll also get to some additional Q&A as well if we have time. So several months ago, we asked members of the COVID FP task team for IBP if they had a preferred format for delivering task team information about learning, program learning related to COVID and family planning. And many task team members were in favor of creating a map. And as you can tell, we're very excited about it. And we had originally talked about using this map to make connections and to visualize innovation. So as Trinity showed you in the little demonstration, we really are already visualizing that and hoping that people can use the map to get connected to others and learn more about what others are doing. So really that coordination piece is really a key aspect of this map. We're also hoping that we can continue doing some synthesis presentations and sharing some key learnings from the map. And also potentially doing some deep dives into some of the examples. So, you know, specific countries or specific topics or themes. This could include things like, you know, what HIPs were adapted, if any, what adaptations had worked, what they've learned, how they can be applied. I noticed a couple of questions related to effectiveness of the adaptations, and people are really looking for more information about, you know, positive or negative impact, how this affected other programs, et cetera. So those are definitely some things that we can keep in mind for future webinars. And as Trinity mentioned earlier, we can also look into the question of how these adaptations continued over time and how they continued to adapt. So those are some of our thoughts and some things that we've been sort of mulling over as we prepare for additional webinars. And I think we can now go into some of the Q&A that's been coming in through the chat. And we still do have about 8 minutes. So if you have additional questions or comments, please keep them coming. But I'll start with a couple of questions for the PSI team. I know there was a lot of interest in the PSI map, how it can be used, and some specifics. So maybe Eva, if you could answer the question that came in about the, sorry, I'm losing my place here. Both what didn't work well and why, and if you're capturing and publicizing that information. And then there was also a question about if it's possible to share prevention of unsafe abortion partners group map. So if you could take those, that would be great.
Great, thanks, Sarah. This is so fantastic, and all the other presenters. What a fun way to start the day. So I really appreciate the questions about, okay, did these adaptations work, and now what are we going to do about it? And I think, and that's been top of mind for us at PSI for the last several months. And I think, you know, we are saying we hope to figure out which ones were just sort of mitigated COVID transmission in the moment, but really were not better than the programming we had in the first place, and which ones really advanced access to care and should stay in place. But I think in order to answer those, I think we have sort of anecdotal feelings about what's working, but that's not going to fly, really. I think we need to do a proper evaluation of some of the common themes that are emerging to figure out the answer to those questions. And so I think that requires us to sit down soon and say, how are we going to map out that evaluation? We can't do it for every single adaptation that we have on our map. There are, I don't remember, over 300, 350 adaptations, but I think we need to pick some that seem to be emerging as working through sort of formative comments from the program people on the ground, and then design an evaluation that could really has some salt to it. So that's our hope. Stay tuned. As far as the prevention of unsafe abortion map, that will be coming to you soon. We need to finalize some of the qualitative pieces and get some permissions, as it's a 7 or 8 organization group. We need to make sure all the consents and things are in place before we share that widely. But we hope to do that and probably disseminate it for the first time through a similar channel like this, and then be able to make it live. So thanks for the questions.
Thanks, Eva. And Trinity wrote in the chat that for the IBP map, in terms of learning about whether a program will continue to adapt and how that adaptation is working, we are gathering information from these programs. Not all the adaptations will have formal evaluations, but if they do, we can link out to that evaluation data if that exists. So those are really great questions about kind of what we're going to do in the future and how we can use the map. Trinity, I'm wondering if you can say a little bit more about what this map addresses. There was a question about if the map addresses only family planning or other reproductive health interventions.
Sure. At the moment, it has been limited to family planning, although I think there's certainly interest, I can tell, among audience members to see perhaps an enlarged definition of SRH. And so that's certainly something that we can look into through different collaborations. I also note a lot of really interesting comments and questions about integration with other services, whether that be mental health or GBV or HIV. And I think that that's a really interesting perhaps consideration for a filter. So it's something that we can also look into. Of course, all this is dependent on people populating with information. So again, I'll just put the plug out. We can go to the website, go to the Google form, submit your information. But I think it would be really, really interesting for us to be able to include that filtering, perhaps, FP exclusive or FP integration with others, so that we can start to see what types of adaptations may actually have shifted toward more integration with other services. That would be really, really interesting.
Yeah, I agree. I was just going to mention that there were a number of other sort of health areas that have been mentioned in the chat: health and development areas, humanitarian populations, mental health, HIV. So we can capture those as well. I know that there's a lot of interest in that. There was also a question, and this maybe goes to Trinity or if PSI presenters have comments. But the question is there any thinking around identifying which and why some of these impacts can be high impact adaptations? So I guess looking at the various adaptations and seeing which ones are high impact.
I mean, I'll just jump in quickly. This is Trinity again. I think it's a great question, and it's absolutely linked to the other question about how we can have a sense of what's working well. And for that, I think we can do it qualitatively, but in order to really identify high impact adaptations, we will need that hard data. And so if this effort can help drive the conversation and then perhaps dig deeper to conduct some additional research and really be able to definitively say this was a high impact adaptation, that would be a huge and beneficial outcome, I think. But it would require some extra legwork for sure.
Exactly. And I'm not sure if that question specifically referred to the high impact practices, the specific HIPs or not. I don't think it did, but we've also gotten questions in our task team about how we can link this to the HIPs themselves. So that's another thing that we could keep in mind. I'm recognizing that we just have a couple minutes left, so I'm wondering if I should hand this back over to Nandita if there are some closing remarks. I know we want to be respectful of everyone's time, so thank you so much to all of the questions and comments that have come in, and we really look forward to continuing the discussion.
Great. Thanks, Sarah. And just to echo your comments, thank you to all the presenters. We really appreciate the time, and to our partners who took time to input the data. I think both Trinity and our colleagues from PSI mentioned that, on the ground, there's a lot happening during this pandemic, and really taking the time to help to share your experiences through these maps has been really important and influential. So thank you all again. Just a reminder that the webinar will be recorded and we will share the slides with those of you who joined today. And again, you can see on your screen, feel free to join the COVID-19 task team at the links below, and please do take a look at the map and do submit your information so we can grow it. Thank you again and enjoy the rest of your days. Bye.